My name is Oluwatoyin Adegboyeg. I'm here to present my Doctor of Nursing Practice scholarly project. The title of my project is Multidisciplinary Education, Evidence-Based Measure to Improve Hyperphosphatemia in Dialysis Patients. I will start with the abstract. This quality improvement project was conducted to assess how a multidisciplinary education approach can provide improvement of phosphorus levels and self-efficacy among patients with end-stage renal disease on hemodialysis. Pre and post-intervention blood laboratory results showed and self-efficacy showed statistically significant improvement after a multidisciplinary education was conducted. Introduction. The kidneys are the main organs for phosphorus homeostasis and excretion. Phosphate excretion is hindered in patients with end-stage renal disease on hemodialysis because the kidney excretes about 90% of phosphorus daily. So when the kidneys fail, the ability for the body to excrete phosphorus is hindered. Approximately 40% of patients at the DNP site in a given month had hyperphosphatemia, meaning their phosphorus is high, above 5 milligrams per deciliter. Normal phosphorus level is 2.3 to 4.7, but around 5 for a dialysis patient is still seen as acceptable. Anything above 5 definitely is a concern. The goal of the DNP project is to translate current best practice into an existing clinical problem. Hyperphosphatemia was a clinical problem at the DNP site. Multidisciplinary education has been proven to reduce hyperphosphatemia in dialysis patients. Several studies have shown this improvement. For example, Yin et al. In 2021 in their study titled Implementation and Effectiveness of an Intensive Education Program on Phosphate Control Among Hemodialysis Patients, a non-randomized, single-arm, single-center trial saw improvement in phosphorus among their study population. The knowledge of phosphate control and adherence to phosphorus binders increased significantly in their study population. Also, Chan et al. In 2019, in their study titled Multidisciplinary Education Approach to Optimize Phosphate Control Among Hemodialysis Patients, also utilized multidisciplinary education to lower phosphorus in their study population. The study participant knowledge of phosphate, adherence to phosphorus binders, and phosphorus levels increased significantly. So multidisciplinary education has been shown to improve hyperphosphatemia in dialysis patients. Before the implementation of this project, the usual practice at the DNP site was for the dietitian, a member of only one discipline, to provide education. Hence, the high rate of hyperphosphatemia among this population. The usual measure to control hyperphosphatemia is three-pronged. First, adequate dialysis. That is the work of the nephrologist to prescribe adequate dialysis for patients, so that because dialysis removes phosphorus, excess phosphorus, when the kidneys fail. The second measure is for patients to be placed on phosphorus binders. The clinical pharmacist is an expert in this aspect. Then the third approach is for the patient to be placed on phosphorus binders, and rather to be educated on selection, foods and drinks that are lower in phosphorus for them to eat so that their phosphorus will be at goal. So there are different disciplines that are involved in measures to lower phosphorus in dialysis units. So having just the dietitian doing this at the DMP site was not making lowering phosphorus to be, if measures to lower phosphorus to be effective. It needed to be done in a multidisciplinary manner, hence the implementation of this project. So the specific aim of this project was to use multidisciplinary education to reduce rates of hyperphosphatemia at the DMP site, in which the dietitian will be involved, the clinical pharmacist will be involved, the nephrologist who provides dialysis, writes prescription for dialysis will be involved, and the nurses who see patients daily when they come to dialysis will be involved. And they are seasoned and knowledgeable. These nurses are seasoned and knowledgeable. Many of them have been dialysis nurses for more than 10 years. They are well equipped to educate patients. The goal is to have all these people sit at the table to be involved in phosphorus management at the DMP site. The first thing that the DMP student did was definitely to seek the approval of the leadership at the DMP site. The clinic, the leadership, the director of the clinic, the nurse managers, these people were approached, and definitely they were all concerned about this problem at the DMP site because hyperphosphatemia has some risk. Some of the risk associated with hyperphosphatemia is cardiac problem. Hyperphosphatemia causes cardiovascular problem in dialysis patients by promoting vascular calcification, whereby calcium deposits build in the blood vessels, leading to decreased blood flow. The number one cause of death among dialysis patients is cardiovascular problem. It also impedes hyperphosphatemia also impedes peripheral vascularization and causes lip ischemia, leading to amputation. So amputation is another problem among patients with hyperphosphatemia. These patients also, their eligibility for transplant candidacy is lowered when their arteries are hardened. They are not eligible for transplantation. Hyperphosphatemia also causes other problems such as skin irritation because calcium deposits on the skin causes itching, and then poor quality of life from having to take so many pills because they don't have the self-efficacy to manage their phosphorus. So addressing and keeping phosphorus at goal, lowering phosphorus and decreasing hyperphosphatemia is a measure that will lead to good care outcome among this population. So the first thing that the DMP student did was to seek the approval, like I said, of the leadership at the DMP site. Also, the approval of the IRB at the Maryville University to conduct this project. Once the approval of these sites were sought, the DMP students then started a retrospective review of electronic medical records to select patients meeting the criteria to participate in this project. Patients with hyperphosphatemia, meaning their phosphorus level 5 and above in the 3 months preceding implementation of this project and who met other criteria for participation, such as age greater than 18 years, ability to read and write in English, on hemodialysis, not on any other modality except hemodialysis, and who are in chronic dialysis units and also have been on dialysis for at least 3 months prior to the implementation of this project were selected. Exclusion criteria included age greater than 18 years, inability to read and write, on hemodialysis for less than 3 months before the implementation of this project, and on hemodialysis but are in acute dialysis units with the exclusion criteria. Only patients who are stable in chronic dialysis units who have been on hemodialysis and have phosphorus level 5 or greater in the 3 months preceding the implementation of this project were recruited. Once the patients were selected, then the formation of the diet education team, the multidisciplinary team that participated in this project. The team consisted of a nephrologist, 5 dialysis nurses, 2 dialysis technicians, the clinical dietitian, the clinical pharmacist, and the social worker. The social worker was brought in because patients may have some social issues that were impeding their ability to control their phosphorus. So all the team members working in dialysis units were involved, were represented in the diet education team. The usual practice is for dialysis patients to come to dialysis 3 times a week. Usually Mondays, Wednesday, and Friday, or Tuesday, Thursday, and Saturday. They usually come either in the morning or in the evening, or in the afternoon rather. So plenty of opportunity to see these patients because they come 3 times a week. The patients that were selected were approached and they were told that their phosphorus level was high and they will participate in this project. The usual practice at the DMP site was for all patients whose phosphorus level was not at goal to be approached by the dietitian to provide education. So having the multidisciplinary team members conducting this education was not something that the patient were not used to. The usual practice was for them to receive education from the dietitian monthly. But now the education will be conducted by a multidisciplinary team. The multidisciplinary team came together to uh, to uh, to create a phosphorus binder, a phosphorus pamphlet to be used for this project. The phosphorus pamphlet was a comprehensive educational material that had information on what is phosphorus, how to lower your phosphorus, uh, foods that are high in phosphorus, foods that are lower in phosphorus to choose from, how to read labels, food labels to identify foods that are high in phosphorus, the the uh, the negative side effect of hyperphosphatemia was also discussed there, and other measures like how to take your pills with your meals, making sure to come for dialysis, how to prepare food to lower phosphorus. All this were information on this pamphlet, phosphorus pamphlet. And like I said earlier, all the members of the diet education team came together to produce this educational pamphlet. And then the self-efficacy questionnaire was also developed. This was an 8-item questionnaire adapted from an instrument developed and validated by the Stanford Patient Education Center to evaluate self-efficacy in patients with diabetes mellitus. Since diabetes is a chronic health condition like hemodialysis, the diet education team felt this self-efficacy instrument could be adapted, and it was adapted into a self-efficacy questionnaire for chronic kidney disease. This instrument was submitted to Maryville IRB and it was approved to be used for this project. These were the two instruments that were used for this project. This phosphorus pamphlet, and the self-efficacy questionnaire. The study started May of 2024. The very first month of the implementation, all patients received education on diet by a member of the DE. A member of the DE team approached the patient to provide education. After the education, each patient received the phosphorus pamphlet to take home to read, to reinforce the information that they received from the DET member during their education session. Each patient also received a self-efficacy, pre-self-efficacy evaluation using the self-efficacy questionnaire. This was completed on all patients the very first month of the implementation, the month of May. All patients also had their laboratory phosphorus monitored starting the month of May. The project took 12 weeks or 3 months to be completed, meaning the month of May, June, and July. Intensive education on all patients was done the month of June by a member of the DET. Starting the month of June, weekly, every patient involved in this project had a weekly follow-up by a member of the DET. The student researcher, the DNP student, met with each patient routinely, weekly, starting the month of June. Also, all patients in the dialysis unit had some education provided to them utilizing puzzles and games such as Kahoot and other activities just to give them more information and education on phosphorus. There was an ongoing education weekly in the dialysis unit. At the end of the intervention, each patient had their self-efficacy reevaluated. So the month of July, at the completion of the project, each patient that participated in this project had a post self-efficacy evaluation done. And like I said earlier, their laboratory phosphorus was monitored monthly as well. The project implementation was completed at the end of July. Data collection started the week of August and completed the first week in August and was completed the last week in August. The analysis. Peer sample t-test was used to analyze the laboratory pre and post phosphorus values. Non-parametric test, Wilcoxon sign test, was used to evaluate the pre and post self-efficacy data because this data did not meet the requirement for parametric testing. The result, the pre and post laboratory phosphorus was significant when the t-test was used. The two-sided p-test for this test was p equals 0.004. For the pre and post self-efficacy, the Wilcoxon sign test p was less than 0.001. For both tests, the statistical significance was set at 0.05. So there was a significant improvement in patients' phosphorus and self-efficacy after this multidisciplinary education was conducted. The bar graph here showed the improvement in the phosphorus level and the self-efficacy after the multidisciplinary education was conducted. Clinical significance: hyperphosphatemia occurs frequently in patients with end-stage renal disease on hemodialysis. Multidisciplinary education improved phosphorus levels and patient self-efficacy when multidisciplinary education was introduced. The improvement in phosphorus and self-efficacy to manage phosphorus after multidisciplinary education was statistically significantly improved when compared with education that was done only by the dietitian. So multidisciplinary education definitely improved phosphorus much better than when it was done by the dietitian only. The project facilitators was a support at the DMP site, project site, and the support from Maryville University. The barriers: the time for the implementation was very short. Like I said earlier, only 3 months. Also, another barrier was a rather small patient population. The population for this project was only 21 patients. The pitfall and unintended consequences: unplanned change of patient status during this project was an unintended consequence. Some patients received kidney transplantation, which made them ineligible to participate in this project. Also, predominantly male population. The patients who participated in this project were males. There were very few females at the project site, and even though they participated, if they met the criteria, their data was not presented here. Implication for nursing practice: nurses play pivotal role in diet education and in measures to improve hyperphosphatemia in dialysis patients. They are there every time the patient comes. The clinical dietitian only comes in most cases once a month to meet with the individual patient, whereas the nurses are there all the time. The frequency of nursing contact with patients on dialysis builds trust and facilitates rapport, promoting education and treatment compliance. Implication for future research: I would say for future researchers, I would suggest for them to expand their sample size. Also suggest that patients on other renal replacement therapies, such as peritoneal dialysis, be involved in their study in the future. And also with those with advanced kidney disease, especially stages 4 and 5, who many of the times too, some of them have issues with hyperphosphatemia because of their decreased kidney function. Also incorporate daily daily food log so that they can be able to have a good understanding of how patients are selecting food, and if they have the self-efficacy to select the right type of food to lower their phosphorus. These are my references. I want to use this time to appreciate my project chair, the chair for this DMP project, Dr. Gordon West. Thank you so much. My current teacher and all the teachers that have passed through during this being in this school. Thank you so much. All of you contributed to the success of this journey. I am very grateful. These are my references. Thank you so much for taking the time to listen. Have a good evening. Thank you. Bye.